holds the NHS accountable? Exploring democratic and clinical governance models. Accountability is the cornerstone of trust. But in a system as vast and complex as the NHS, accountability is not always clear. Who holds the power, who holds the responsibility, and who holds the system to account when things go wrong or when they need to improve? So to our panel, Professor Jagtar Singh, CBE, former Chair of Coventry and Warwickshire Partnership NHS Trust and Professor of Leadership and Inclusion at Warwick Medical School. William Pett, the Director of Strategic Engagement for Health Watch England. Phoebe Dunn, the Senior Policy Fellow for the Health Foundation, and Helen Hughes, Chief Executive of Patient Safety Learning. A general one to all of you, just because you're at the top and in the top corner on my screen, Helen, I'll start with you. When we talk about accountability, who do you think patients and the public ultimately see as responsible? Is it at the government level or does it filter down? Who do you think patients see as accountable, and are they right?
Well, I suppose my experience comes from working 20, 25 years in patient safety and recognising the critical importance of listening to and responding to the perspectives of patients, particularly if things go wrong, if there's avoidable harm. And often patients and families will immediately hold the clinician that's been part of that team that's provided the care as accountable. And clearly that's the case. You expect professionals to provide safe and effective care. I think what patients and families don't always understand, and I think society is increasingly recognising, is the complexity of providing care, and that it isn't just the immediate clinicians that you see, it's the whole infrastructure behind you. You know, is the organisation, does it have the right culture, does it have the right leadership? Are clinicians provided with the resources that they need to provide the right care? Whether that's, you know, have they got the right information about the right patient? Have they got the right IT equipment? Have they got the right medical devices? You know, are those facilities available? So I think immediately, particularly if something goes wrong, patients and families will look for accountability to the professions that are providing that care. And sometimes that might be a little unreasonable because they may just be working in an unsafe system. So there are professional accountabilities undoubtedly, but how do you hold the system to account? And then you start moving up that hierarchy, leadership, organisational hierarchy. So, you know, the boards of those organisations, and then NHS England that funds it and sets strategy. So I think there's layers of accountability, and I think particularly some patient organisations who are campaigning for better healthcare based on harm, like, say, Kath Sanson running Sling the Mesh, they're recognising that the changes that need to be made are policy, they're government, they're funding, and they're at NHS England level. So I think there's an increasing recognition that there are layers.
Jagtar, do you concur with that it's all a bit more complicated?
Right. Many years ago, I went to a conference, and a learning point to me was, as an ex-fire officer, when you put a problem in front of me, I put water on it and it goes out. That's a binary answer to every question. But I've learned over time that every question is very complex. So complexity theory is the way that I would answer it. Yes, Helen's absolutely right. There are structures, there are systems, there are methods of holding people to account. However, if I go back to my fire learning, who was accountable? I was accountable because I was the chief fire officer. I was responsible for everything that happened on my watch. And I don't feel that accountability in the NHS. I don't feel that board members feel that they're responsible for the disproportionate disciplines under arrest for Black and Asian people. I don't feel that individual accountability is taken seriously. And part of this question is about trust. How do you build trust? You can't build trust with your patients. You can't build trust with your staff if you don't feel that personal accountability and you don't take learning from every incident. Final comment. I'm also fed up as a senior person, a public servant. I've seen people standing on the steps of courts, standing on the steps of headquarters saying, oh, this is an emergency that happened. We'll learn the lessons from this. Well, what happened the last time this particular type of incident happened? Why haven't you learned the lessons from that? So we need to learn lessons, apply lessons. And the final point is, I'm also really disappointed that a model that was set up under NHS trust, foundation trusts, so the public could hold the boards to account, is something that appears to be disappearing into the background. The public, according to the NHS constitution, are the shareholders of the NHS, and therefore they should be holding boards and leaders to account. And we're moving further and further away from that. And people like Helen are having to set up charities to hold the NHS to account. That was fundamental part of the NHS foundation model, that governors would hold them to account.
Yeah, I mean, I think the question of accountability is really interesting, isn't it? A lot of our work is focused on what accountability looks like at a more local level. So we've done work on integrated care systems in the last few years, understanding the kind of governance and accountability at that level. And what we've seen is it's really complex. We know how variable integrated care systems are across the country, and what that means is almost each one of them looks very different in terms of how the local governance works. They've had a lot of permissiveness and flexibility over how they organise some of that, and too much over how they set themselves up, and not over kind of what they actually can do. They vary hugely in terms of size, organisational complexity, how you bring those different partners in and hear those voices around the table. So I think it's, in terms of governance and accountability at a more system level, it's quite hard to kind of say how it's working in a typical system because they're all so different. And we know that the accountabilities in particular around things like trust performance or other elements have been quite opaque between looking up at the regional and national bodies and looking up to the role of ICSs in holding trust to account over some of those elements. Sorry, my screen is dotting about. I'm hoping my eyes aren't going all over the place. And yes, I wanted to pick up on, Jagtar's point, which was there's a lot of changes underway at the moment to the NHS, aren't there? We've had a lot of changes in the last year. We've got another raft coming down the line. And I think it's actually really unclear as to how some of these governance and accountability issues are going to land, how some of these changes are going to align. The potential abolition of local and national health, what real implications there, that loss of independent mechanisms for patient and public voice in these decision-making processes. So I think looking ahead, looking back, it's unclear, and looking ahead is also quite unclear and some big challenges too. Will, I'm not sure.
Yep, he sorted out the fire alarm.
He's
We're all
nodding,
good.
so,
The fire has been put out. Jagtar's jumped in, put the fire out for you. Off you go, William.
The fire's been extinguished. Yeah, thank you very much. I really like to talk about accountability from a patient perspective, from service user perspective, because accountability is really important. But often in health policy circles, when we talk about governance and accountability, we go straight to kind of some of the structures and mechanisms. We talk about ICB board representation. We talk about health and wellbeing boards, patient participation groups. These are all really important structures, but they don't mean anything to most members of the public. So instead, I suppose what I'm interested in this conversation is how we can foster more of a culture of accountability rather than just a kind of theoretical governance framework that's going to solve all of our problems. And when it comes to culture, accountability for patients is often things like having the opportunity to ask questions, share your view on local services, being confident that sharing your views will actually result in improvements being made in your local area. And really, it means encouraging something that we often don't do that well in the NHS, which is two-way rather than one-way communication. Something that helps with that is something like a single point of contact for patients when they're on a pathway. This doesn't need to be somebody who has all the answers, but often patients want somebody who not necessarily is accountable for their care, but who they can go to when things aren't clear, or where, for example, they might want to make a complaint about aspects of their care. And I think that the NHS does this well, but in pockets. It's not universal. So there's some really great case studies. NHS Derby and Derbyshire ICB have done some great work in doing a kind of Derbyshire dialogue online session for the public, bringing together providers and commissioners to hear from the public about what's causing problems with services. And that results in tangible outcomes, which are then fed back to the patients that have left that feedback. So it can be done. But what I would say is that at the moment in the NHS, the things that we don't have much of are kind of support, capacity, and resources. And those are exactly the kinds of things that are needed in terms of fundamental ingredients to being able to engage properly with patients about the future of their services. So for me, that's what accountability will mean for the people that we represent.
Helen, I know you wanted to jump in.
I do. I'd actually might link some of those comments that my colleagues have said, but going back to Jagtar, I mean, it does frustrate me. You mentioned about being on the steps of a court. I see, senior leaders on the TV, head slightly put to one side, hands being wrong, saying we've learnt lessons. I don't want to hear that. I want to hear, what lessons have you learnt? What are you going to do differently? How are you going to make improvements? How are you going to evaluate that? And how are you going to share that more broadly so that no one else has to go through avoidable harm, that the learning is shared more broadly? And interesting, Jagtar, that you mentioned about your role in fire safety. With patient safety, we have a very dispersed and as Phoebe said, there are different operating models about how people do this, but we don't have a chief safety officer in each organisation in the way that if you were in other industries, safety industries, you would. It's very diluted, and people aren't always trained and expert in that. But the fact that the government even are having to move to legislation suggests that that culture that you all talk about isn't there. The fact legal framework around duty of candour and now introducing the Hillsborough law, basically don't lie to the public. The fact that you're going to have to go to law to do that shows that that culture of transparency and accountability isn't as well developed as it needs to be. And I think my final point is there's a big initiative around PSIRF, which is the Patient Safety Incident Response Framework, about how you respond to when things go wrong, and different and better quality investigations and reviews. And part of that is compassionate engagement with patients and families. It's an excellent aspiration. The models are well developed. We're hearing that people just aren't applying it in a way that they would want to, and consistently, because they don't have the capacity, they're not prioritising it possibly, and sometimes people don't have the skills working. Love to hear more about the Derbyshire work, but working with families and communities, it's not like just putting a nurse in front of a family and saying off you go. It's really important, particularly when people might be bereaved or in severe distress, that we work properly to listen to them.
Okay, Jagtar, I know you want to come in. Can you keep it brief just so we can move to the questions that are coming in?
I think the question of accountability again falls here. So when a leader is speaking on the steps and saying, we will learn the lessons, does the interviewer actually says, hang on a second, Grenfell, for example, there was a fire last year, was there not, in a high rise? And you said you learned the lessons from that. There was a similar lesson. So why have you not applied those lessons?
Paul Baker says, as a governor of a mental health trust, I've just received correspondence from a family member whose son has died. She's been waiting for a response from the trust for a year. She's CC'd me into a letter to the CEO and the chief nursing requesting a meeting within 14 days so that she can escalate to the ombudsman. She believes the trust senior management are counting the clock down and waiting to the last minute before responding. Why does this happen? I don't know which of you is best placed to answer that one.
So as a chair of a mental health trust, I would always openly meet with individuals. However, the legal teams would say, wait until the coroner's inquest. So there could be a defensive mechanism put in, because the legal teams are saying you don't meet with the family until the coroner. However, good practice would say they have had a loss, therefore let the medical director at least meet with the person. So somebody from the trust should be meeting that person, explaining why they're not meeting them or offering any more information, because the information, it may be a criminal investigation, the police may be saying don't do anything, it may be the coroner doing the blocking, it may be legal, but a compassionate board leader, chief exec, would take some action to give feedback and factual information.
Tanya, can I come in on this one?
Yeah.
And I think this is kind of part of a broader problem that we hear from patients, which is that the experience of giving feedback is so poor. And we've done some dedicated work, particularly on the complaints process. And we polled people that had gone through the complaints process, and just 1 in 5 told us that they'd had a positive experience of doing so. It's partly because of delays and how long it takes to get any kind of response from services, but also being kept abreast and updated about what's happening to your complaint after you submit it. Often patients are left in limbo for weeks and months, not knowing if anybody's heard the complaint, whether any action is happening, when they can expect to hear any kind of response from services. So the process at the moment, unfortunately, is really poor, when we should be trying to gather feedback and complaints data as kind of a gold mine of data for improvement. So unfortunately, because of that process being so poor, again, polling shows that just a quarter of the public say that if they had a poor experience using NHS services, that they would take action. And at the moment, that is a hugely missed opportunity. So I think that the question really kind of helps to illustrate what I think is a much more common concern across members of the public, which is at the moment, even just getting answers from services, leaving feedback is such a miserable experience for people.
Could I jump in on that, Tanya?
Yep.
From a kind of a personal experience and a system experience. My mother passed away just over a year ago. In the last few years of her life, I had a lot of engagement with the healthcare system as she as she was provided support. A lot of it very good, but some not so good. And it was really difficult to know how to give that feedback. I'd say, look, I've got some insights that might be useful to you in understanding what it felt like, some of the inefficiencies, and seeing the patient's journey through some fairly complex cares, hospital, and then ultimately to social care. And there was no real mechanism for having that discussion. It was all, well, do you want to make a complaint? No, I don't want to make a complaint. I want to share that experience so you learn from it. So I don't think we're sufficiently sophisticated. And maybe the example you gave, Will, about Derbyshire, that, we need different mechanisms. But the systems point I was going to make was that I used to run, on behalf of Dame Julie Mellor, when she was Ombudsman, I used to run the PHSO service. So you see, as the top tier of the complaint system, you see how the awful experience that people have that you've highlighted, where often it's very poor and ungracious communication. It's, where patients will feel that they are being deliberately excluded and there's some sort of conspiracy. It may just be hopelessly inefficient, but nevertheless, the experience is being blocked, and they're not feeling that they can trust the people and what is being said, that it's defensive. And I know that I had nothing to do with it, sadly, because I think it's very good. PHSO have got complaint standards that are excellent, but not everyone adheres to those. So I think when we're looking at accountability, who is making sure that some of the models of good practice are being implemented? Is that CQC's role? Do they look at that as actively as they might? Because I think when there is good practice, we want that to be shared and everyone to apply it.
Hannah Willoughby asks, individuals have been held accountable for too long, not systems, undue pressure placed on staff or poor infrastructure and facilities. How can accountability be built into systems and the NHS be just transparent about the flaws in the system while making them better? Phoebe, do you want to come in? Because we haven't heard from you for a little bit.
Yeah, I think it's a good question. And I think at the moment we also see some of that reflected in how, for example, approaches to poor performance in the NHS, often focus on leadership changes or executives or, management, and actually don't focus enough on the system, kind of the system pressures or the system level features that, as the question alludes to, crumbling buildings, poor capital, really high varying population needs, all those things kind of contribute, don't they? And I think we don't necessarily see those reflected in the approaches to both support poor performance to improve. Often it's kind of a carrot strangling for the high performers, and not on a focus on how we can support people or organisations to improve. I don't know if others come in on that one as well.
Will, you look like you're poised to say something.
Yeah, it's a really interesting question. I think that as a health and care system, we do need to move away from a kind of individual blame culture when things go wrong. I don't think it's conducive to actually failures being brought to light in the future. And I know that when there have been previous sessions about accountability and blame, the aviation industry has been looked to as an example of where there is a kind of no blame culture, but actually crises and failures are investigated, and coming forward to reveal failures is something that is encouraged rather than something that's going to end up getting you sacked.
Can I just jump in on there, just because this question absolutely leads where you're going. With Joy Edwards says, how can we build accountability and trust when whistleblowers are pursued and harassed, often to the point of leaving or being sacked? There is a lot of blame in the no blame reporting system. Very much the point that you're making, Will.
Yeah, I think we have to go much further on this, and learn from other sectors where there are lessons. I think from a patient perspective, I don't actually think that often patients do want a single individual hung up to dry and blamed for why there have been failures. I think what matters to patients is, why has this happened? Why have I or a relative experienced such poor care, or in the worst cases, kind of serious failures? Why has it happened? What will be done to ensure that it doesn't happen again? And often those things are covered off when there are reviews, either at local or national level. But the thing that I think crucially is missing is when we set out to patients what will be done to ensure this doesn't happen again. What we need is timelines. We need a commitment to evaluation at clear points in time to assess whether things have got better. And really importantly, we need ownership and responsibility for delivery. And often those things are crucially missing, which doesn't give patients the clarity they need to be able to hold services to account in 6 months, 12 months, however many years down the line. So I think there's a long way to go in terms of giving patients the information that they would want to know when failures happen.
Jagtar, I'll bring you in a second, but Helen, I know you've done work on whistleblowing, haven't you?
Yes, I mean, culture is key to all of this, as colleagues have said. And going back to the Francis report, as a consequence of mid-staffs, the introduction, the fact that you had to formalise something like the Freedom to Speak Up Guardians to have a safe space for people to go to. But on the whole, people that are accessing Freedom to Speak Up Guardians are usually talking about workplace disputes rather than patient safety issues. But when staff do what they are required to do under their professional conduct, they speak up if they can see that there's a risk of harm to patients, and sometimes organisations respond appropriately, but other times they are absolutely vilified. And we've been working with a whistleblower, Peter Duffy, stood down now as a doctor. He's sort of retired, and he works as the health lead for Whistleblowers UK. And we've got a whole series on our free learning platform, the Hub, Patient Safety Learning, a whole series of interviews with whistleblowers. And we see this kind of deliberate whistleblowing playbook where organisations will marginalise staff, will prevent them from accessing professional advice or legal advice, that they become the enemy to be removed. And I mean, it's just it's horrifying, the experience they go through. And we need to absolutely eradicate that culture. We need to embrace the patient family voice, but also the staff voice who are raising genuine concerns. And we need the leadership that will respond to that and take that as insight to help better understand risk and to make improvements in care. But if anyone wants to look at failures of accountability in regard to whistleblowers, do have a look at that interview series. It's alarming, and there's much work to be done here.
Jagtar?
3 tools that the public should be aware of. Institutions have been institutionally discriminating, racist, and structurally making mistakes. And why are they doing that? Even though after the death of Stephen Lawrence, there's a equality impact assessment required that have eliminated all these institutional discriminations. So public should be aware that when something goes wrong, ask for the equality impact assessment that would have determined that. The next method is to actually turn up to the public meeting and send a question to the board of your concern. And then the final one that I would just recommend, there's loads of legal tools. I don't want to go to everything. Just 3 simple ideas. Is find out who the Speak Up Guardian in the organisation is and go and speak to the Speak Up Guardian. There's 3 simple things that you can do to see if the institution is structurally discriminating, structurally causing harm or inequalities for a group of people. Most of the structural harm is happening in postcodes rather than going through the binary protected characteristics. So postcode lottery is something that we ought to be calling out a lot more. More people get harmed in poor postcode areas. That's another learning from the fire service. The fire service have worked on prevention for 3 decades. And what's the result? By working on prevention, we've gone from 800 deaths a year to 200 deaths a year now. We've reduced the number of firefighters. Imagine if we had done the same thing in the NHS, reduce the requirement in the number of hospitals because we're working on healthcare prevention rather than trying to cure people once they get ill.
A question for you, Will, from Michelle Scott. In relation to engaging with the people we serve, have you heard about Care Opinion, an online platform that offers staff an opportunity to hear from service users and are able to respond back, offering a 2-way communication method and showing service users if and when changes are being made based on the feedback they get?
Yeah, I am aware of Care Opinion, and I think that Care Opinion does a fantastic job. I think that it's a really useful platform for patients. I think what I'd say is that unfortunately, we still have a very confusing landscape of feedback mechanisms for patients. Care Opinion is one. Patients can often, what they'll do is go on Google and leave a Google review of their hospital. They might go to the PALs in their hospital if they have a question or some concerns. They might leave a formal complaint, or indeed they might go, of course, to their local Health Watch. And I have a vested interest in representing the Health Watch network today. So Care Opinion is one of, at the moment, many ways in which patients can leave feedback about services, and it's very confusing. And that's what Penny Dash, as chair of NHS England, when she did her review in the last couple of years, sought to address, is to make this confusing landscape more simple. I worry in future that we are heading towards a kind of fairly simplistic kind of review-based feedback structure where the government has talked a lot about feedback mechanisms through the NHS app, and we now have league tables introduced for trusts, which is publicly accessible, and I slightly worry about this kind of quantification of feedback, treating kind of patients almost like customers, this is a customer feedback exercise, and where I see some risk in future is patients being able to tell their own stories in their own words, and the importance of qualitative data, people's stories. We're just awash with stats. We have so many performance stats the NHS is held to account on, and I worry about that kind of almost staticizing of patient feedback in future, where everything is reduced to a 5-star rating. Care Opinion is part of the puzzle, but I think there are risks in where we're headed in terms of the feedback landscape.
Helen, you want to jump in?
Yeah, absolutely. I mean, I'm a big fan of Care Opinion. I think they do great work, but obviously that's varied because some organisations resource and support that, and a lot of the feedback through Care Opinion does come from people providing very positive feedback, which is very, given the pressures on the NHS, it's great for staff to hear that. So that's fantastic. But it is a very kind of confused landscape, and I worry too about the transactional nature of that. The idea that you can just have a bite-sized chunk of information and it's for the benefit of the professions that the patient provides that information. Actually, this is a relationship issue, and if patients and families are sharing information, they will want answers, they will want a discussion, a dialogue, and hearing those stories. Often patients and families will see aspects of care in their long journey that may weave across a number of organisations, primary, secondary care, different departments. There's a richness in that insight that I just think, one little paragraph feedback button on the NHS app isn't going to capture that, and that's a missed opportunity.
I'm conscious, Helen and Jagtar, that we are going to lose you in a couple of minutes. And Helen, there's one question that's directed at you from Angus Wallace. One of the problems is that even the NHS staff often do not know how the system works, and they are not in a position to give honest answers. How would you address this?
Yeah, I mean, healthcare is complex and complicated, and it's not always clear for, as Angus says, if people are working within the system how it works. But that's where you need to go up to that accountability level. We've seen it. I'm doing some work with how organisations are responding to coroners' requests for information at inquests. And if you're asking a band 5 nurse about how the system operates, you're asking the wrong person, because they won't know. It's not their role. They can contribute their insight, but you do need to have that accountability. Whether it's your chief nurse or the chief medical officer that has a patient safety responsibility, they need to be able to provide that sort of answer, and bringing that connection between the professional accountability and the system accountability. That's the leadership responsibility of the organisation, whether it's the executive leadership, non-exec, or as Jagtar says, in terms of governors holding the organisation to account on behalf of the local population.
Jagtar, is there any points you just want to make before you have to go?
My final comment would be, let's stop giving awards to HSJ top chief execs. Let's start giving awards to people who listen and act upon what they hear.
So I think we've had one from Rachel Scott, so I'm going to just try and get somebody different. Julia Walsh says, how do human factors play a part here? It's easy to put in actions to prevent future incidents occurring. However, it's harder to ensure thousands of staff comply. With the avenues of communication we have, how do we ensure the staff read it all, given the previous speaker stating we're seriously under-resourced and overwhelmed with changes? Phoebe, do you want to lead on that one?
Yeah, I mean, kind of a point I was going to pick up in what Will was saying earlier as well, in terms of the challenge in organisations and staff having the capacity and the headspace and the resources to respond to some of the feedback that is received and that does come, that is communicated to them. So I think sorry, I've lost the question, but staff capacity to respond to this and engage in the many kind of bits of guidance and new information that's issued to them is a major challenge. And I think in terms of responding to this stuff, that's where some kind of function that can support organisations to improve is really critical, and to have some organised way of doing that. At the same time, I'd echo what Will said about the risk of kind of losing that connection with local services and aggregating up all this feedback at a higher level to make it in a way more packaged up and easier to understand. That the role of that unsolicited feedback and feedback at a local level is really critical. And we've seen that in kind of some of the insights from patient and public voice organisations. So maintaining both those levels is really important. But I think, major challenges around staff kind of morale and headspace, resources, capacity to kind of engage with this. And Will, I'm sure you've got insights from the work you do as well on that one.
Well, yeah, I mean, what I'd say is that a lot, I've talked about how dissatisfied members of the public often are with feedback mechanisms and specifically the complaints process. That's not the fault of the really hardworking, diligent staff who are doing their best to make that system work amid incredibly difficult circumstances and pressure. So I think that staff are doing the best job they can in a very, very constrained system. We've seen across ICBs that there have been headcount cuts over the last kind of 18 months. It's kind of engagement staff that are bearing the brunt of that. So things have got even harder for staff to try and improve feedback and engagement processes. And the other thing I'd say is that I think that there's, when we look at patient safety, there seems to be a link between how well the NHS supports its staff and how high quality and safe services are. Kevin Fong is somebody who speaks really articulately about this, and there is now a kind of increasing academic evidence that it's only by supporting staff that we are going to make services higher quality and safer for patients. So I think that the staff voice within this conversation is paramount importance. And yeah, I'd be fascinated to talk to somebody in the NHS who is actually responsible for a complaint service, because they will give you a really kind of, I'm sure, warts and all account of why it's so difficult to improve those services for patients.
Paul Baker says Health Watch is going. Governor bodies are probably being removed. What's the new accountability system to local communities and other stakeholders? I suppose that leads on, doesn't it? What are the lines of communication here?
Yeah, so I'd say it's a good question. I obviously have a vested interest in the answer to that question. I mean, what the government would say in response to that is that Health Watch functions, for example, are being brought into ICBs and local authorities at kind of local level, and Health Watch England's statutory functions are being brought into the Department of Health. Now, the government's line to justify that is to bring patient and service user voice into the heart of policy making. Now, of course, the obvious risk that creates is conflict of interest, and one thing that I would really urge and have been urging decision makers to value in what the new world looks like is independence, because I worry that as soon as you lose an independent patient voice, who is going to be blowing the whistle on the failures we see across services, who's going to be drawing attention to bad news, particularly on access to services, and who's not getting access to services. I worry that this is the kind of news that a government might want to understandably keep quiet. So that's the risk of where we're headed. And at the moment we're trying to urging and working with government on some mechanisms that could try and alleviate that conflict of interest and still have some semblance of independence. But it's a challenge, and those challenges have been set out better than we could have done by the King's Fund, who have published a report on evaluating the Health Watch model over the last 13 years and the lessons that should be learned. So I'd encourage people that are interested in this to read that King's Fund report, because it makes some important recommendations to government on independence.
Phoebe, that independent piece, it is important, isn't it?
It is, and I think it's really hard to see with the current proposals how that patient public voice is being strengthened and not diminished. NHS organisations have a mixed record of listening to public and the patients. One of the proposals that some of these functions transfer to ICBs, well, we've heard already, they've undergone major cuts, they've got real capacity issues. Will they have the resources, the information, the skills, and the legitimacy actually to do this effectively? That independence that Will was talking about is really one of the the crucial things that we need for this to work. So I think we need a stronger replacement that's currently on offer that looks at that includes both an independent mechanism at local and national level, can capture those local views but also influence nationally, and that is adequately resourced to kind of do this work. So yeah, I'd agree with Will on that one.
And Tanya, can I just say a final comment on this, which is that what I found from engaging extensively with service users is that people don't really want accountability in silos. And what I worry about in the future is that responsibility for listening to patients on the NHS will fall to ICBs, and on social care to local authorities. But of course, we know that a lot of the problems that patients find is in the gap between those services. So who takes responsibility in future for all of the interface issues between the social care and NHS sector, of which there are many and affects huge numbers of people? And I slightly worry about, in future, that's not my responsibility becoming a more common answer to people, which is exactly what they don't want to hear when they've got a problem.
Peter Bell.
One final just reflection on that one, Tanya, if I can, is also just that ICBs are now covering very large populations and very large footprints. Some of them, the biggest one in London, is now 4.5 million people, isn't it? So that's also really changing, if that function sits there, really changing what information is gathered at what level. You're losing kind of that local nuance potentially, and the loss of engagement with sort of more seldom heard or vulnerable communities. So I guess that's the other kind of dynamic that sort of worries me about the proposals that are currently on the table.
Yeah, Peter Bell says, when I was a public governor at an NHS trust, we formed a subcommittee of governors who met with patients and or their families to hear complaints directly from them. So it can be done if the will is there, and a complaint was only considered closed when the complainant had confirmed that they and only they accepted that the complaint had been dealt with. Why does the panel think, sorry, there's only the two of you now, but why does the panel think NHS trusts in general don't have a similar mechanism?
Yeah, and I mean, I would absolutely agree with the question. I think there's so much further that we can go on this. I'd encourage the audience, if they're interested in particularly like where some of the improvements to the complaints process can be made, to read our report. And a bit of a shameless plug, but we published a report I think last year, which is called A Pain to Complain. It sets out some of the reasons why patients find it so frustrating to try and leave complaints, but it sets out a really comprehensive list of recommendations on how the complaints process can be improved. We know that there are pockets around the country of areas, trusts, individual trusts that are doing complaints much better than others, but unfortunately they are pockets. A lot of trusts, I would say at this point in time, aren't giving the resource and the priority to the complaints process that they should be. And again, it comes back to huge numbers of competing pressures with limited resources. But I think there are things that can be done. So I'd encourage people to read our report, and really happy to pick up any conversations on this offline as well if anyone wants to get in touch.
Phoebe, just before you answer, I just want to bring in one last question because we've got 1 minute left. Samantha Hudson says, what is the optimal mechanism to share and learn from patient feedback, taking into consideration that it's currently a miserable process? How do we improve that process?
I can try and answer that one, but I actually think Will's probably got a better answer. So Will, I'll let you have the last minute.
I mean, it's a really good question. I think there's a lot that we can be doing to build patient feedback much more into how we commission and plan services. I think that there's huge things that we can do in the new world to use AI to help people to understand large quantities of feedback. It's something that we've kind of done a bit of, but I think we need to be doing much more. Fundamentally, I also think that when we look at the main reason why people don't leave feedback, because they don't have any confidence that it's going to improve services. So actually, I think we don't need to collect more feedback. What we need to do is start building in mechanisms that demonstrate to members of the public that when they do leave feedback, it is actively leading to tangible improvements to their local services, because we know that's what motivates people to leave feedback in the first place. So we've got a long way to go on this.